Level 5, Fellow. Fellowship is 1 year. Adult reconstruction, 260 hip and knee replacements in 12 months. 6:30 a.m. You sit in the locker room with a laptop and review CT scans for 3 Mako cases. You plan the implant position in the software before the attending arrives. First case is a direct anterior total hip. You do the approach, the cuts, the trialing. The attending scrubs in to confirm the balance, nods, and leaves for his clinic. The second case is almost the same. The third case you do with a fellow from another program watching. By January, you stop thinking about the steps. Your hands know them. The instruments move before you ask for them because the scrub tech learned your rhythm in the first week. By February, you're faster on primaries than the attending. The Mako learning curve for the anterior approach is 19 cases. You hit it by Thanksgiving. You start turning rooms in 55 minutes. The nursing staff notices first. The attending notices second. Your stipend is $78,000. You're doing attending level work for PGY1 money. You defer income for another year. You sign a lease in a city you didn't choose. The subspecialty decision is effectively permanent. 92% of fellowship applicants apply to only one track. Spine surgery pays $710,000 to $844,000 a year, top of the specialty. Pediatric orthopedics pays $410,000 to $560,000, bottom. You were told the choice was about passion. Most of your co-fellows quietly factor in $700,000 a year times 30 years. The lead apron fits better now. You've been wearing it for 5 years. The shoulders of it have shaped to yours. You stopped noticing the weight sometime in PGY2. You don't remember when? Your first job interviews start in September. You fly to 4 cities. 4 dinners with 4 different partner groups. You choose the one who seemed honest about the call schedule. You sign the contract. Level 6, junior attending. Month 4, as an attending, $450,000 on the contract. A Wednesday. Schedule is a routine tibia, ORIF, on a 32-year-old who fell off a ladder at his house. Healthy. No comorbidities. Incision at 10 a.m. You reduce the fracture. The plate goes in. You're driving the 4th distal locking screw. Fluoroscopy flashes. The angle is wrong. You pull the drill back. You look at the image. The bit is in a place it should not be. The drape darkens. Dark blood. Not surgical bleeding. A different color, a different volume, a different pattern. Anesthesia says his pressure just dropped 20 points. The drill punched through the back of the tibia. The popliteal artery runs behind the bone at that level. You pack that question away during a PGY2 exam. It's in the room again. The room changes temperature. You pack the wound. You press. You tell the circulator to open 2 units of blood. You tell anesthesia to call vascular. You tell the tech to hold the pressure exactly where your hand is before you let go. You call your senior partner. He's driving home from his satellite clinic. He'll be there in 40 minutes. Anesthesia hangs pressors. His pressure comes up. Then it drops again. Then it holds. You're standing with your hands in a 32-year-old's leg, and the only thing you can do is not move. Vascular gets there in 36 minutes. 2 surgeons and a fellow. They prep. They repair. The repair holds. The patient goes to the ICU on a norepinephrine drip. His leg stays attached. You scrub out at 11 p.m. In the locker room, you sit on the bench for a long time without taking off your shoe covers. You don't call your spouse. The senior partner doesn't hear from you either. Driving home takes 28 minutes. You sit in the driveway for 14 more before you go inside. This is what the papers call second victim syndrome. It starts before the patient leaves the OR. Racing heart. Tingling skin. You replay the drill angle at 3 a.m. every night for a week. Up to 40% of young trauma surgeons report the syndrome. Almost none of them tell a colleague. You're back in clinic Monday at 7 a.m., 18 patients on the schedule. The production model doesn't give you a day to recover. You close 18 notes by 7 p.m. Nobody can tell. You're on a partner track. 3 years probably. You generate attending level revenue on associate wages. The hospital employed position down the road would pay more now, but not later. Every junior attending in the country is doing this math in the same week, and most of them get it wrong the first time. The partner who scrubbed in to save your patient tells you at the Christmas party that the first complication feeling never goes away. You nod. You don't believe him yet. You buy in. Level 7. Partner. Year 12 as an attending, $850,000 a year. You own equity in a 12-surgeon group. Your buy-in cleared in year 8. 7 a.m., 3 total hips before noon. The Mako arm guides each cut. Your hand is on the handle. The CT data loaded last night. You planned the implant position at home at 10 p.m. while your kids were asleep. The robot is doing what you told it to do 3 hours before the patient woke up. 12:30 p.m. partner meeting about OR block time for the 3rd quarter. 3 partners disagree. You generated the most RVUs last quarter, and you have the least input on the schedule because you joined last. Your vote counts half of what their vote counts until year 10. You wait. 2 p.m. clinic, 18 patients, half of them post-op. You close 18 notes by 6:30 p.m. with voice dictation in the car and again at the kitchen counter. Drive home. Pass the mirror in the hallway. Don't look. The lead apron has been on your back for 11 years. The MRI last spring showed a small disc bulge at L4, L5. Your spouse doesn't know. Your partners don't know. The spine surgeon down the hall would do the procedure for free if you asked him. 13% of orthopedic surgeons meet criteria for depression. 26% of them seek help. The rest don't. The medical board asks on license renewal, and they can't answer yes. Orthopedic surgeons are 28.2% of all surgeon suicides between 2003 and 2017, highest proportion of any surgical subspecialty. A missed day empties an OR block and reschedules 40 patients. The work week never came down. Private equity bought the group next door last year. The 3 associates they hired aren't on a partnership track. They're on profit share in a PE-managed entity. The job you trained for is being re-engineered by people who have never held a saw. The lead apron kept you safe from fluoroscopy. It also carved a groove into your spine. 5:50 a.m. on a Monday, a medical student walks into the OR on their orthopedic clerkship rotation. Third year. They've been reading the layers of the hip capsule on the drive-in. The attending is already scrubbed, 14 years into the job. A lumbar MRI at home in a manila folder he hasn't opened since spring. He hands the student a retractor and tells them to hold the leg. The student holds the leg weighs 60 pounds. Halfway through the exposure, the attending asks about the layers of the hip capsule. The student answers. They get it mostly right. Neither of them looks at the other for long. The student doesn't know about the MRI. The attending doesn't know the student has already decided to apply. Neither of them knows about the Christmas party 12 years from now. It's where the student will tell a junior attending the first complication feeling never goes away. The drill pitches up. The student hears the whole frequency. The attending hasn't heard the high end in years. In 14 years, the student will be scrubbed across the table. The retractor will weigh the same.